I do have some disclosures, which I'm told I have to tell you. I was a speaker for Azilect because I really like Azilect and I think it worked. And now I'm a speaker for Nupro because I really like Nupro and I think it works. And I eat lunch offered by anybody. So if you want to buy me lunch or bring me lunch, I'll eat it and I'll listen to your story. My other disclosure is that we're all just competing for second place. I'm not nearly as entertaining as Alexander. It's just not going to happen. I always like to start with this specific case whenever I give a talk. This is when I give talks to other doctors or if I give talks to anybody. I always love bringing up this specific case. And I'll go through this quickly, and then I'll ask who this sounds like. So this is a 72-year-old gentleman, 11 or 12 years, weakness in his left hand, started having some tremors. Later noticed that his right side was affected, then his legs became affected. Always had some trembling at rest, but if he changed positions or if he noticed it, it would stop, but then he would come back again. His handwriting was hardly intelligible for the past couple of years. He walked, and I always like these sentences, he walked with under much apprehension of falling forward and had difficulty restraining himself from breaking into a running pace, and he had difficulty in raising his feet if he saw a pebble in the road. So who does this sound like? Anybody here? Exactly. And what's interesting is this was written 200 years ago. This was directly out of James Parkinson's essay of Essay palsy, which was interesting because he literally sat on a park bench and noticed people walking by him. But the long story short is not a lot has changed since he wrote the initial book and what we still look at today. I mean, this is exactly what walks into my office 10 times a day. I have these same conversations, and it hasn't changed since he wrote it 200 years ago. I put a question mark for a reason. Is Parkinson's disease a movement disorder? Well, kind of. I call myself a movement disorder specialist for a reason. Is it more of a neuropsychiatric disorder? I mean, anxiety and depression and these things go along with the movement component all the time. Sleep is a problem. Is this an endocrine problem or a hormone problem? Is this a neurogastrointestinal problem? It always starts in the GI system, depending on who you read. This is a big area of research these days, constipation and so on and so forth. Well, it's all the above. It's what I like to call it as a full body disorder. It's a full person disorder. It affects everything. Top to bottom, left to right, it's pretty much affected by having this type of condition. The hard part is even though everything is affected, mood, sleep, walking, running, tremors, your whole life is affected. This is still how you make the diagnosis. So you have to have these symptoms. This is where the diagnosis comes from. It's still diagnosed based off of the motor components. Bradykinesia just means it's just it's the only fancy word I ever use. It's just a fancy way to say you're slowing down. That's all it means. I think it's Greek, slowness of movement. Tremors, stiffness, postural instability. These are the cardinal features of Parkinson's disease. You guys all know this. This is what you live with every day. And this is how you get the diagnosis. And so even though it affects everything, all your systems are affected, we still make the diagnosis based off of the motor components. I put the DAT scan in there just because people think, oh, DAT scan, that's going to diagnose my Parkinson's disease. It doesn't. It just tells us that we're going in the right direction. It's still based off of the symptoms. But in terms of the diagnosis, there is one symptom that you have to have or you can't get the diagnosis. Any guesses? Arms? No. Tremor? Good guess, but wrong. Because everybody has a tremor. That's what they come for. Smell? No, that's usually where it starts, but no, that's not how. It's not a necessary. No, constipation's everywhere. Everybody has it, but again, still not it's the one nobody thinks about. It's actually the slowness of movement. You can't get the diagnosis without having slowing down. Now, I will tell you, I've never seen somebody come to me who was shaking and stiff and falling who also wasn't slow. So I don't think you can have all the others without that one. But that's the one that you actually need to get the diagnosis. Tremors are what people most commonly come to me for because that's what you notice. All the other things that were mentioned are always brought up. Loss of sense of smell, constipation, talking in your sleep, postural instability, stiffness, can't roll over in bed, can't get in and out of a car, trouble getting up out of a sofa. I hear all these things because everybody has them. They're all the common symptoms. But you can't get the diagnosis without bradykinesia. But it's not the most common complaint. Nobody comes to my office and says, "Doc, my biggest problem is I'm slowing down." They say it, but that's not their biggest problem. So what's the answer to this question? What'd you say? Rigidity? Not usually. Not the most common one. I'll give you a hint. We just had a whole lecture on this that was done fantastically by Dr. Susky. Fatigue. Everybody that comes into my office is tired. But you don't need to hear me talk about it. You just had a great talk about it. These are the things that people complain about the most. All of my patients who are in the audience know the answer to this question because I talk about this more than any other thing that I talk about in my office. So yeah, I'm glad everybody knew the answer to that question because this is exactly what the biggest problem is. This is the most dangerous problem. I have yet to see a patient who shook their way to the hospital or who slowed down their way to the hospital or who stiffed their way to the hospital. They all fall their way to the hospital. And there's three things that I always tell all of my patients, which if you're my patient, you've probably heard me say this. There's three take-home messages. You need to exercise, which we're going to come to in case you were wondering. You have to stay off the ground, and you have to stay out of the hospital. Keys to success. So you might say, well, okay, falls. That sounds bad, but how bad is it? Well, I went and looked for you. Don't worry, I did all the research for you. You don't have to do it. And I'll tell you if you come to my office. This is just one of a whole bunch of studies that you can find. So I just simply typed in a search, why do patients with Parkinson's disease go to the hospital? Two main reasons in every study that I've seen. The first and most common is infection. You get sick with something. Urinary tract infection, you get a pneumonia, you get the flu, you get a cold. Something triggers your infectious or your immune system, you get an infection, you end up in the hospital. You get your flu shots, you get your Pneumovax vaccine, you stay away from sick kids, you do all the things you can, but that's not entirely avoidable. But number two is always falls. It's trauma, fall and break your hip, fall and hit your head. This is how you end up in the hospital. Now you might say, why does it matter? You're a doctor, you're in the hospital. Isn't that a great place for me to be? Of course not, obviously. Good answers. So why do you need to stay out of the hospital? I only half believe this number. How many people here have been in the hospital? How many people feel like their Parkinson's symptoms got worse when they were in the hospital? Right. I think 20% is such an underload number that I almost find it hard to believe. Every single patient that I see who ends up in the hospital comes back and tell me that they got worse, 100% of the time. I don't know where they got 20%, but I found two studies that suggested 20%, so I had to list it. Couldn't argue with research. I just find it low. 44% of people, when you go to the hospital, don't get back to how good you were before you got there. Right. That's why you got to stay out. 3/4 of people who were admitted to the hospital had a problem. They either didn't get their dose of medicine, their medicine was late, which we'll get to, and 10% or 34% of people miss 10% of their doses. So that's a huge amount of medication. And you guys know this better than I do. When you're at home, you get your medicines right on time. You know when you need your pills, you take them. You're in the hospital, you're at the liberty of other people, and that's not exactly in your best interest. Nurses have an hour on either direction to give you your pills. 75% of people don't get their medicine correctly. Again. 31% of people are dissatisfied with the way their Parkinson's disease is managed. And this is probably the most important one. Half of people who go to the hospital are back in the hospital in that year. Again, this is why we got to stay out of the hospital. That's why I tell people this. Walking is how you stay out of the hospital, or not falling is how you stay out of the hospital. Again, there's not a lot I can do to prevent you from getting sick, but there's a lot of things we can work on to try to keep you upright. My physical therapist is here, and I'm sure he'll correct all the things that I tell you about walking that's incorrect. But the long story short is there's a bunch of different parts of walking. You know, I get up and walk across the room, and I don't think about it. It's how it's supposed to work. You want to get up and walk across the room, you have to think about each individual part of walking across the room. You want to start walking across the room. Well, you have to think about taking that first step, right? Picking up your foot, shifting your weight to the other side. Straight walking is probably the walking that requires the least amount of thinking. It just naturally happens, and yet it doesn't for people with Parkinson's disease. Turning is always a challenge. When's the time you're most likely to lose your balance? It's when you're turning. So what does everybody do when they're in my office and I make them walk down the hall? They pirouette like a ballerina at the end and they try coming back. And I say, well, this is why you're going to fall. Don't do that. Unless you're Alexander Tresser. Then he's allowed. I'll give him a pass. Adaptability. If there's things in your way, it really throws off your walking. And it really becomes a big challenge. Even if it's something simple or something like a rug. Something that's only a quarter inch up off the ground is enough to make you tumble. And then freezing of gait is a whole aspect of walking in and of itself that causes infinite problems. And all of these problems or all of these parts of walking are really hard to fix, especially with medications, which is why we spend so much time and having a giant conference about exercise. In case anybody didn't pick up on the theme, it was exercise. I stole this picture from this study that I quoted, labeled down here at the bottom, and I'll come back to what it was actually intended for. But the best way to look at this picture is the bottom. This section is pretty much what normal walking is supposed to look like. This section is what it looks like mostly for people with Parkinson's disease. Let's talk about how you start. So again, you want to stand up, you're standing, you want to move forward. You have to shift your weight to one side, you have to take a step with the other foot. You don't generate enough force to do that. And so, you throw yourself off balance when you try to shift weight to one foot because your balance is affected. And you don't really push off far enough, so you take a really short first step. It's not as big as it's supposed to. And then the length thereafter continues to be worse. But the longer, because it's slower and because you can't generate enough force, you tend to have more difficulty just standing on one foot or shifting your weight over to the foot that's supposed to hold you up, and that really throws you off. So in this case, when you're looking up here where the first step is, look how much shorter that is. And then your steps become asymmetric. That's throwing you off balance. Straight walking, which should be just the easiest part of walking, the part of walking that requires the least amount of thinking, is also affected because, again, you're not generating enough force, you're taking short shuffling steps. You have a weak push off, you spend more time with both feet on the ground, and that really throws off your balance. You can't generate enough force to swing your arms because they're stiff, and so you always have an asymmetric arm swing, which you can try to fool me when you get to my office, but you can always tell the difference between somebody who's thinking about swinging their arms and somebody who's swinging their arms naturally. It just doesn't work. Your step-to-step variability. So each step isn't the same distance apart. Part of that is because one side's always worse than the other. And that stiffness really throws off or adds more variability to the walking that you have. And all of this leads to less balance, more instability, more risk of falling. So again, going back up here to the top part, asymmetrical steps. So this side seems to be closer than the other. You tend to shuffle or have these close footsteps. And it's variable as you take step and step, which throws you off balance. Turning. If I go to turn, my eyes go first, my head goes second, my trunk and torso go third, my pelvis goes next, then I turn. That's not what happens when you guys try to turn. When you try to turn, everything tries to go at one time. It turns into this slow, jerky movement that really just throws you off balance. It requires a lot of steps. So normal people take a couple steps to turn. You take short shuffling steps that make you eventually turn all the way around. That keeps more time where your center of mass, which it should be in the middle, should be in between your feet, is off. And the more time you spend with your center of mass outside of your base of support, that's what this picture is showing, the more likely you are to fall. If that center of mass is not in that red square at the bottom, which is your base of support between your feet, it really throws you off balance, and you're much more likely either to drift or go that direction or fall over completely. Adaptability is very hard. If you're walking and you run into something, or if you come across something in your way, it's very hard to get around it or get over it. You end up with a lot more left to right movement than you're supposed to when you're trying to go forward and backwards. And again, this throws your center of mass out of where it's supposed to be. It leads to less stability. It also takes you longer to get over something, meaning you have more time left on one foot. And if you haven't tried standing on one foot for a while, you should. It's good balance practice, but you'll find that it's very difficult for you because your balance is affected. Freezing of gait's a huge problem. And this is exactly what it sounds like. If you haven't experienced freezing of gait, well, count yourself lucky. There's probably somebody at your table who has, and they can tell you just how bad it really is. It has to do with everything I just mentioned. So your stride-to-stride variability, more time spent with both feet on the ground, asymmetry between trying to move your right and left legs. All of these lead to more freezing, more postural instability, less kind of appropriate step taking and appropriate balance and walking. You might say, well, why is freezing such a big issue? So what? You stop. Eventually you start going again, which isn't completely inaccurate, especially if you use cueing or techniques like that, but it's a huge problem. How do you predict who's going to fall? Because that's really useful information. Again, I already said you have to stay off the ground. I already said you have to stay out of the hospital. It's actually fairly simple. I forget where these people were out of. I met this group when I was at the Movement Disorder Conference a couple years ago. They had this on a poster, and I wrote it down. It's that easy. You just look. Who fell in the last 6 months? Well, that really makes you likely that you're going to fall in the next 6 months. Who has freezing of gait in the past month? That increases your risk of falling in the next 6 months. Who walks slow? Well, everybody walks slow. That's part of the diagnosis, but that really makes you at higher risk. Who has all three? Well, a lot of people do. And if you're in that high, and I wrote down the numbers just so you could see what they were adding up. If you're in the high risk group, unfortunately, you have a high chance of falling in the next 6 months. So somehow we have to try to work on these things. Somehow we have to prevent you from falling. That takes away 6 points. We have to work on freezing of gait. That takes away another 3 points. We got to work on speeding up your walking. Again, this is how you go from the high risk group down to the low risk group, which is where you want to end up, because again, we got to keep you out of the hospital. So that obvious next question. Okay, you already told me I can't fall and I have to stay out of the hospital. How do we do that? Medicines are iffy. Again, especially when you're talking about walking and balance. I have tons of medicine. I have no shortage of medications, as you know if you come to my office. But do any of them work? Well, sort of, but you've already figured this out. There's plenty of dopamine medicines. They keep coming out with new versions of carbidopa, levodopa. It helps some of the parameters, so it'll help speed you up a little bit. It'll help your amplitude or your swing or your stride length a little bit. It doesn't seem to help you turning when you're just standing there, but there's some evidence to suggest it helps you if you turn or change direction when you're walking, although to some extent. It questionably helps starting, maybe. Maybe it helps with freezing of gait, but it never brings those parameters back down to normal or to people who don't have freezing. But it certainly doesn't benefit for the cadence that you have with walking or how much time you spend with both feet on the ground, which again, play a role in throwing you off balance. There's plenty of dopamine agonists, there's plenty of COMT inhibitors, there's plenty of MAO inhibitors. Believe me, we have no shortage of medications, but at the end of the day, are they really all that helpful? Not really. Not in this specific case. They are much better at treating tremors or stiffness or helping you get up out of the chair to some extent. But walking imbalance is a really hard problem to fix with medicine. I use a lot of amantadine. Amantadine is a great medicine. It's an old medicine, but it has some benefit in terms of walking. And so I will generally, if I'm trying to fix somebody's walking imbalance and I have to give them a medicine, I'll try amantadine. Although that didn't pan out in really the new fancier trials that they were hoping for, we have some suggestion that it does help. Maybe it helps a little bit of freezing of gait, although not tremendously. We use other medicines that were invented for other things. A lot of the dementia medicines. I happen to like rivastigmine, that's Exelon. I put people on it because I think it does help with a little bit of balance. Rivastigmine and donepezil, which is Aricept, tend to help cognition, and there's a big cognitive component of walking and balance. Memantine is Namenda. It's another one that works similarly to amantadine. Maybe there's some benefit. Droxidopa is new. It's used for blood pressure control, and we use it for people whose blood pressure goes down. But it also may have some benefits for walking. And methylphenidate was used for a long time without much data, and the newer data doesn't really support it, but we still try it. So you might say, well, why do you keep trying these medicines that there really isn't good evidence for? And it's because I don't really have anything better to give you when you come to my office and your balance is off. The medicines just don't fix the problem. They can definitely make the problem worse, though. Absolutely. Antidepressants can be sedating. They can throw off your walking and balance. Antipsychotics make everything worse. The opioids, again, coming back to sedation. Benzodiazepines, same thing. These actually can throw off your balance in and of themselves. Even some of the antihypertensive agents, so if you come in with blood pressure problems, some of those can make your walking and balance worse. And the anticholinergics, which sometimes we use for stiffness, we use it for tremors, can actually make some walking worse. And so not only do we not really have great medicines to try to help, we also have medicines that oftentimes a lot of you may be taking that can actually make it a little bit worse. And so part of it is trying to keep you off of medicines that make you worse. Try medicines that have some benefit to get you doing better, but we know that medication really isn't the best answer. There's always other choices. In fact, I'm not a big fan of giving you more medicine. The more medicine that I give you, the more likely you are to call me with a problem with said medicine, and it's really just so you don't call me as much. It's all about me. I also prefer not to cause you problems, but it's more about me. There are other places you can stick DBS leads to try to help with balance. As we know, or if you may or may not know, most of the time when we traditionally stick the deep brain stimulator leads, walking can get a little bit worse as opposed to better. There were some people in Canada that were aiming for this nucleus here. Problem is it's in your brainstem, and nobody really wants to drill a hole and stick wires into your brainstem unless we have to. So you can imagine people aren't all that eager to get on board. There's a little bit new evolving evidence about transcranial stimulation, either direct current stimulation or magnetic stimulation. It's hard to find people who have this technology or who can do it. It's mostly research at the moment, but maybe there's some benefit with walking there. We talk about wheeled walkers. Excuse me. We talk about canes. This is why I have a physical therapist who helps me direct people to the right assistive devices, although I hear time and time again, oh, my cane just trips me. And so using it correctly and having a correct device makes a lot of sense. There's a lot of cueing devices, which you can read about or you can learn about. There's auditory cues, there's music, there's laser line shoes, which I don't know if you've seen those ones yet. There's all kinds of fun stuff that they keep coming out with. I told you I would come back to this picture. I actually stole this from a paper called Into the Groove, Can Rhythm Help with Walking in Parkinson's Disease? And what they were doing on the top part, that's what you guys normally look like. That's where your short shuffling steps and your poor initiation come from. And on the bottom is actually when they had them listen to a rhythm. And after some training with some music therapy or something that has a steady rhythm and steady beat, you could actually time your steps to it. A metronome works too. And you can actually use it to take bigger steps and actually have better balance. That's where I stole that picture from. I thought it was fairly interesting. That's a laser cane and the laser shoes, which I tried on in the office one time. The hard part about the laser shoes is you can only get them in Europe, I think, and they cost infinite dollars, much like everything else that's helpful in Parkinson's disease. And the idea here is that if you have something to step over, it's better to initiate that step. That comes back to the whole cueing aspect, which physical therapy can help with. But if there's something on the ground, you'll be much easier to step over it as opposed to initiating your own step. This has been the theme. This is the theme in my office, every visit. I ask every patient, what are you doing for exercise? How much are you doing? And how do we get you to do more? Except for the one person I met today who's exercising twice a day already, every day. I'm hard-pressed telling him that he should exercise 3 times a day, but if he comes to my office, I might. I always get to people that say, oh, but I do laundry, and I do dishes, and I walk up and down the steps. And I say, oh, that's fantastic. It's not exercise, though. Exercise to me means you're getting your heart rate up. And they actually came out with recommendations for exercise last year. 150 minutes of exercise that gets your heart rate up a week. That's a half hour a day, 5 days a week. Again, it's a lot of exercise. Has to be intense. The more intense, the better. You can't exercise enough to make me happy, except for that guy. Physical therapy. I send patients for physical therapy all the time. That's why I have a physical therapist in my office most of the time. It's so important to work on these things. But physical therapy is short. Nobody gets physical therapy forever. Everybody gets kicked out. It's insurance dependent. And so eventually it comes down to you guys taking it upon yourselves to do the exercises. And physical therapy, speech therapy, it's one of those if you don't use it, you lose it things. You have to keep it up. You have to keep it going if you want to see the results. And that's why I love this conference. Every single person basically was telling all of you guys the same thing I tell my patients every time they're in my clinic. Exercise is so important. The more intense, the better. As much as you can do. Keep a positive outlook. Go out and socialize. These are all the things I tell my patients all the time. There's tons of papers on this stuff. There's no shortage of data out there that suggests that exercise is the best medicine for you. Getting up, moving, walking, working on balance, these are the best ways to try to get you doing the best. The obvious next question that I always get after I tell people you really need to exercise, and if you're exercising, you need to do more, is what kind of exercise should I do? And what's my answer? I don't care. Usually, it doesn't matter as long as you do it. All of this stuff's been looked at, from walking to dancing to Tai Chi and Pilates, and the boxing class is big, which I love because it works on balance and everybody really enjoys doing it. There's cycling and pedaling. There's probably a few other that I skipped over. Pickleball's big in the Parkinson's disease community. I was going to say, I think I put a picture of me playing pickleball, which didn't go so well. If you ask David, he was on my team. We were iffy at best, but it was fun nonetheless. It doesn't matter what kind of exercise you do. It just matters that you do it, and you keep doing it. And so usually my answer is find something you like to do. If you find something you like to do, you like to do it, so it'll be enjoyable, but more importantly for me, you'll keep doing it. You're much more likely to keep doing something if you have fun, or if you're having a good time, or if you're doing it with other people, or if you're enjoying it. And again, coming back to the fact that exercise is the best medicine for you, you have to do it for the rest of your life, or at least until you hit 100, because that's when I tell you can do whatever you want. Find something you like to do and find it now, because I'm always going to ask you about it. That's just a bunch of studies that I used to come up with all that data that I just wowed you with. And I'd be more than happy to take any questions unless David gives me the axe and makes me get off the stage. So a couple things. So the question was, he read something, probably in England, that's where they have less strict problems or issues with doing research over there, that he read something about stimulating the spinal cord in terms of, I'm assuming, walking and balance. And so there's actually a little bit of data in spinal cord stimulators, which is a whole different problem. Most of the time, spinal cord stimulators are used for people with back pain or pain that goes down a leg. But there's a little bit of data in Parkinson's disease that perhaps that helps with walking and balance. I can't say that I've had a tremendous amount of people go for that type of therapy yet. I don't think it's written in stone that that's a great way to try to help people walk better. But if I have somebody who has Parkinson's disease and their walking isn't so good, and they also happen to have back pain, which is not uncommon, or back pain and leg pain, and they've done all the things such as physical therapy or injections, they don't want an operation, then I do consider, hey, maybe this would be somebody that a spinal cord stimulator would be helpful for, not just in terms of their pain, but also potentially their walking. So I think the data's still out on that, but there is some to suggest that's helpful.
Walking and gait. Is it always carrying something? When you're carrying something with pain on it, that makes a little.
I can't argue with any of that. So her comment was every time she's walking, she's carrying something. Unfortunately, we always have a lot of things to carry in our lives. A purse, a bag, groceries, something. And that definitely throws off your center of gravity, your center of mass. It definitely puts that outside of your base of support, and you're going to be much more likely to fall if you're doing that. Or if you're carrying heavy things up and down steps. Bad idea. I don't know how you get around that. Unfortunately, we live in a world where you have to carry things. Maybe try to find a cart. The long story short is you're only setting yourself up for danger when you do that. And maybe you're going to get away with it for a period, but it only takes one fall to land you in the hospital. You fall and break a hip, you fall and break your ribs, you fall and hit your head, you're ending up in the hospital. And so you do have to take that into consideration and think about everything you're doing. How much danger is this putting me in? Is it worth the risk? And then go from there. There's no easy answer for that, though.
The laser shoes, does that help something like foot drop?
So the laser shoes, she asked if the laser shoes would help with foot drop. The laser shoes are really to put a line there. So what it does is every time you step, it puts a laser line on the other side. So it aims the laser so if you step with your left foot, it aims the laser line over to the right so that you can step over it. It's mental cueing that comes in to help people with walking and balance. Again, if there's a line on the floor and you have that to step over, it also helps unfreeze people. So if you get stuck or if you have some hesitation, if you have a cue that'll allow you to unstick yourself, that's the idea for what they're going here. So it's not actually a support to lift your foot like a brace. That's more a cue to try to help you initiate the next step. Yeah.
How transient are the benefits that you receive from exercise? Meaning, if you're exercising every day, receiving benefit, and then you don't exercise for 12 hard days, how quickly is that benefit complete?
The question is, how quickly do the benefits of exercise go away? Good question. I don't know the answer to that question. There's definitely an immediate effect of exercise. You know what I hear the most common in my office? I feel so much better when I exercise. And I say, no kidding. Then why don't you do it more? And so there is an immediate effect that people get from exercise, but there's also a longer lasting effect. So as you strengthen up your legs, as you strengthen up your core, as you work on posture, all of which comes with doing more exercise, unless you're a ballet instructor, then you already have it. But there is some longer lasting benefit to it, but it goes away. How quickly does it go away probably depends on how fit you are and how long you've been exercising, but it goes away. It's something that you have to keep doing. Yeah. I like Azalect. That's why I was a speaker for it. I only speak for things that I would use. I have two thoughts on Azalect. Azalect, in terms of medications, is weak. About half of people don't notice a thing when they take it, but half of people really notice a benefit, and so they do get actually symptomatic benefit when they take Azalect. The other reason why I liked it is it's the only medication that we have that had any data to suggest that it actually kept people better longer. Now, the data is not great. It's iffy at best, but there's some. And so if there's anything out there that could potentially keep you better longer, then it's worth it. The downside is it's infinite dollars. And that was true both when it was brand only as well as when it went generic last year. In fact, I had some people where the cost actually went up when it becomes generic, but that's because I don't understand insurance companies. And so I still think it's a useful medicine, but it has its limitations, much like everything else. Yeah.
I've heard people say that ABS is wonderful, but I'm not sure when it would be appropriate.
Well, that's a talk in and of itself. So the question was, he's had people say that DBS is great, but when is it the right time to do it? There's no easy answer to that question. The deep brain stimulator is good. It's good for a lot of the same things that medicines are good for. So if you take your best on period for medication, so when you feel your best, that's really what we're aiming for with surgery. So I think ideally it's good for people who are having a lot of fluctuations, so a lot of ups and downs during the day, people who are wearing off, people who are having complications with the medications. If you're having a lot of dyskinesias or side effects of the medications, there's some data to suggest that we're able to decrease medications after DBS surgery, but it's individualized. I talk to patient on a patient-by-patient basis in terms of when surgery is the right choice. Because it's very complicated to decide when is it worth going to have holes drilled into my head. You know, not exactly a decision. It's not like a flu shot. It requires some thought, some planning, things like that. So there's no easy answer to that question. It would be something we'd have to talk about every visit. Yeah.
DBS doesn't really help so much with the gait, though.
No, in fact, usually I see, so she said DBS doesn't usually help with the gait. In fact, I see it's the opposite. A lot of patients actually get worse from a walking standpoint after DBS. I would not send somebody for surgery who's having predominantly walking problems. Yeah.
I think it's sometimes a misunderstanding with exercise that it's just a strength training thing, and if you go into just an exercise gym sometime and ask them what machines you can use, and it talks about strength training, and I think that really the size of the movements like we got at LSVT Big were important in increasing the heart rate.
I agree.
There's a misunderstanding when people say exercise.
Probably depends on who you're talking to. If you just go to a regular trainer, they're just going to assume that you want to strengthen up, things like that. But you're right. Big. It's called big for a reason. We focus on big movements. In Parkinson's disease, everything becomes more compact, more contracted. So you need those big movements to counteract that. It is a lot about getting your heart rate up, getting the blood flowing. We don't know exactly how exercise works and fixes everything like we think it does. There's a lot of theories out there. But there's a lot about pumping that blood harder and faster and more to your brain. And so you're right. There is a lot of misconception out there about what's the correct thing that you should be doing. And everybody finds their own thing that they're doing. And the most important thing is that you do it. I knew that question was coming. That's the number one question that I get. That also is a talk in and of itself. The short answer is, and this is what I always have to lead with, is there's no data out there that suggests it's beneficial in Parkinson's disease. None. There's no actual evidence or study out there that suggests it's a good idea. But on the counterpart to that is I am a certifier of people with medical marijuana, and so at the end of the day, there's got to be some reason to use it. And the reason is that, again, you have a condition that I can't fix. And if you have a condition that I can't fix, I'm willing to look at everything if there's a potential that it might help you. And so I've been certifying people for about a year now, maybe about 30 people. And I would say outside of a couple of individuals who really had pretty good responses to it, the pure Parkinson's disease symptoms haven't been all that great. So in terms of fixing tremor and stiffness and balance and slowness of movement, my success has been very little. However, I have people who take it and continue to take it because it helps with something else. And so probably what I've found it to be most beneficial for, and this covers both CBD oil and medical marijuana, is more anxiety, pain, and sleep. So those are the things that the majority of my patients who keep taking it, it's usually helping with one of those things. So I'm not against it, but I also have this exact conversation with everybody before we get to that point. So it has to depend on what you're using it for. I think you were the one that brought it to me. And so at the end of the day, I have shared that. So there was a guy in Italy. The question was, what about high-dose thiamine? I forgot I'm supposed to repeat the question. There was a guy in Italy who was looking at high doses of thiamine for everything, including the motor and non-motor symptoms of Parkinson's disease, and he was having a lot of success. I've suggested it to a few people. I haven't seen any data outside of what he did in terms of showing that it's helpful. And I liken it still to a lot of the other supplements that are out there. So I get questions about everything: CoQ10, creatinine, all the vitamins, vitamin D, vitamin E, cinnamon, probably a whole bunch of other things that I can't remember offhand. And at the end of the day, the jury's still out. You're going to be hard-pressed getting anybody who will do a good study on any of these things, so I'm never going to be able to say, oh, yeah, that's a great idea. The science behind a lot of these things makes sense, either through antioxidation, mitochondrial dysfunction, cleaning up debris from cellular mechanisms. There's a lot of science to go behind a lot of these supplements, but there's not a lot of studies or research that say, yeah, this is a good idea. So my general theme or thought or recommendation is you can try them. If they work for you, fantastic. Most of them, as far as I can think of offhand, are not particularly dangerous, toxic, anything like that. And so I don't think there's a lot of risk to them. It's just I can't say for sure that there's necessarily any benefit either.
Have you heard anything about this guy in Japan who's injecting iPS cells into the brain?
So there's a lot of things that are being injected into the brain. The question was, did you hear about this guy in Japan who's injecting, what was it?
iPS cells.
Right. Stem cells into the brain. There's a lot of talk about stem cells. I get questions about stem cells all the time. Again, the data is lacking. There just isn't good studies out there yet. We've been working on stem cells for 10 to 15 years in Parkinson's disease, and there's pluses and minuses that go along with what's been shown. We're injecting all kinds of stuff into the brain. We're injecting enzymes and chemicals to try to help dopamine work better. There's studies that are going on all over to try to help find things that reset or kind of walk the clock backwards to try to get a few more years back to where you were. The jury's still out. We're still waiting. It's always a waiting game in Parkinson's disease, as you've found. Research happens 10 times slower than we think it should. And so we're just waiting for all of these things to happen. I go back to Michael J. Fox's book, his first book, which I read. Back when he was diagnosed, they told him a cure was 5 years away. They still say a cure is 5 years away. In 5 years, they're probably going to still say it's 5 years away. And so research just happens really, really slow, and especially in coming up with major breakthroughs. Well, David hasn't canned me just yet, but oh, go for it.
I'm donating my brain to the brain bank.
Perfect.
And
Not good for you, but
I'm curious if I could talk to someone's family who has gone through this process. Because I want to find out exactly what happens when they take the little section that they need to do.
and that is a great question, which I don't know the answer to, but we can at least get you hooked up with the people who do it to try to figure that out. So she said she's on the registry for the brain bank over at UPMC. They're collecting brains to try to study and really do the research on. And she was asking if there were families who have gone through this process and who can tell her, given her an idea of what to expect if and when these things happen. And I know David has told me a little bit about this, and he may have more information on it, but we'll try to find that for you.
There's actually folks from UPMC, they have, in the corner, if they're still here, they would be happy to get the information.
And I think I'm shut off now. Thank you.